Okay, the title of today's webinar is the Belin ABCD Keratoconus Staging and Progression, Science and Clinical Use. So we try to cover everything around this fantastic Pentacam software application. So Professor Bailey, Michael, I like to hand over to you now. I'm making you the presenter, and we are all interested hearing and seeing your presentation. So you may want to share your presentation.
Okay. Everyone can see this, correct, Jorg?
Yes, we can
Very
see.
good. So I'm going to start. I'd just like to welcome everyone. Good morning, good afternoon, good evening, depending where everyone is. As Jorg already mentioned, it's early morning for me. And as he said, I do have to leave precisely in an hour because it is a work day for me. So what we're going to be discussing today are the clinical applications of the ABCD progression display. And we're going to start off with a lot of background information, because in order to understand the progression display, you really need to understand what went into it and some of the earlier maps. And for some people, this may be redundant, but I think it's very important to go over the background information. And some of you have heard me talk before and have seen this slide. And obviously, none of you are using any of the things that you see on this slide. These are all outdated, 50-plus-year-old devices. So the real question is, if you're not using any of these, why are people still using AMSA-CRUMAC? Even today, you go to meetings, you read papers, and you still hear people discuss AMSA-CRUMAC classification. And this is probably why. It's simple, but it's wrong. And you can see here on the little comic, most people will take the easy way out, even though it's not correct. If we look at the rest of medicine, this is a slide from a number of years ago. I looked at our oncologists and how they stage disease. And I looked at breast cancer. And breast cancer, and this may even, right now, it's probably a couple of years old. They may even have a more detailed staging system. They have something called the TNM staging system. The letter T is followed by a number of 1 to 4. It describes the tumor size and the spread. N is followed by a number from 1 to 3 that indicates whether the cancer has spread to lymph nodes. And M is followed by a 0, 1, indicates whether the cancer has spread to distant organs. And they use a number of different imaging modalities to stage cancer. No one would do treatments nowadays based on a cancer staging that was developed in 1940. They would kind of laugh you off the stage. But AMSA-CRUMAC was developed using a keratometer and an optical pachymeter. My guess is none of you have even seen an optical pachymeter. So let's look at this example here. This is an anterior sagittal curvature map. And would you do surgery on this patient? Well, if you look at the map, it looks very, very normal. It's almost a spherical map, very little cylinder. It looks completely normal. And if we look at the anterior surface indices, you can see here they are all completely normal. So again, we have a normal looking map, we have completely normal anterior surface indices, and the question again is, would you do surgery on this patient? Well, if we look at a full tomographic map, we can see that while the anterior surface is normal, if you look at the lower right map, we have a very positive posterior ectasia. This is what we call subclinical keratoconus. It's true disease. Most of you know I hate the term suspect or form first. You can ask 100 people to define them, you get 100 different answers. But this is true disease. This is subclinical disease in spite of the fact that we have a completely normal anterior surface. And I'm jumping the gun a little bit because we'll go over a little bit about the bad display, but the bad makes the picture even clearer. You'll notice that the final D in this is almost 9 diopters outside the norm, a highly abnormal eye. If you look at every single parameter is red except for the anterior corneal surface. If you look at the first column, it's completely normal. If you look at the front elevation at thinnest point, 4 microns, it's normal. but everything else is red. This is a highly abnormal cornea, true disease, in spite of the fact that it's a normal anterior surface, in spite of the fact that the patient has good visual acuity, and in spite of the fact that Amsler Krumak views this as a normal eye. So what are the limitations of Amsler Krumak? First, it's outdated. It doesn't recognize early disease. But also, let's look at this example. This is a 35-year-old. The apical pachymetry is 485, would put it at stage 2. The mean K is 54, which would put it at stage 3. And the RX is -3, -150, axis 88, which would put it at stage 1. So how do you convey information on this patient? Is it stage 1? Is it stage 2? Is it stage 3? It's really a useless classification that is vastly outdated. Let's look at this example. We have 2 different patients here. The first one is an 18-year-old with a PAC of 410, a mean K of 52, and an RX of -8. The second one's a 47-year-old with a pachymetry of 544, a mean K of 48.5, and an RX of -5.25. And I think if you look at these, no one would look at these 2 patients and say they are similar. One's young with advanced disease, the other one is, older 40s and relatively mild disease. But in Amsler Krumak, these are both graded exactly the same. They're both stage 2. So I know we're starting off kind of a little historical information, but I think it's important to go over what the limitations are of the older systems in order to understand the advantages of the newer systems. So again, the other limitations of Amsler Krumak, it relies on apical thickness. It was formulated using an optical pachymeter. The picture on your right shows a central corneal thickness of 519. Actually, it was 520 at the maximal point. But this cornea actually thinned to 499 at the thinnest point. Again, Amsler Krumak is an apical reading. It's not the thinnest point of the cornea. And as we already said, Amsler Krumak completely ignores the posterior corneal surface. And this is really critical, particularly now that we have modalities other than what we only had in the past 50 years ago, which was penetrating keratoplasty or contact lenses. So again, 50 years ago, our only treatment modalities were for late-stage disease. That's not true any longer. We need something that allows us to diagnose and stage early disease, and that is not Amsler Krumak. So we need a new system, and we need a new system because we have new treatment modalities. We have cross-linking, we have intracorneal rings, dog PK, rigid lenses, but particularly cross-linking, where there's information that suggests that the earlier we intervene, the better we are. The earlier we can preserve vision and not wait till we lose vision, the better we are. And to do that, we need systems that allow us to diagnose early disease before visual loss. And this is not just me saying it. Back in 2015, the 4 major international cornea societies, which are the Asia Cornea Society, Pan Cornea, which is South American, U Cornea, which is Europe, and the Cornea Society, which is international but mostly US-based, came out and said that we have no acceptable classification system. It was really based on this consensus document that I began work on a new staging system. And what did the consensus document conclude? Well, they said the following. The following findings are mandatory to diagnose keratoconus, an abnormal posterior elevation. And again, completely something that's ignored in the Amsler Krumak classification. Abnormal corneal thickness distribution, again, not something you find in Amsler Krumak. And the best current and widely available diagnostic test to diagnose early is tomography, be it either Scheimpflug or optical coherence tomography. And posterior corneal elevations must be present to diagnose early or subclinical disease. All these are completely things that are not available with AMSA-CRUMAC. Yet still, you go to meetings and read papers, and this is what people are currently using. So for those of you who are familiar with the bad display, you know the bad display uses something called an enhanced reference surface. The enhanced reference surface is a surface that's designed to mimic the more normal architecture of the cornea. In other words, for the enhanced reference surface, we exclude, and actually it's a variable area between 3 and 4 millimeters surrounding the thinnest point. And we get a reference surface based on the rest of the cornea. And the reason we do that is when we exclude that, what we call again the exclusion zone, we are removing the bulk of the ectatic region. Well, that's very good for the bad display, and it works again because that exclusion zone represents again the bulk of the ectatic region. And again, it's a 3 to 4 millimeter. It's actually a very complicated formula to decide exactly what the size of the zone is. But in most keratoconics, it's actually a 3 millimeter zone. And it's centered on the thinnest point. And I think that's really critical again. That exclusion zone, not an apical area, it's centered on the thinnest point. And what that does, again, by removing that area, it normalizes the reference surface. Well, instead of removing it, we said it works because it represents the bulk of the ectatic region. We should look at that zone because that zone is a good descriptor of the ectatic region. So we look at a 3 millimeter zone centered on the thinnest point. And we came up with a new classification or grading system. And it's called the ABCD classification. A was the anterior radius of curvature. And again, this is taken from a 3 millimeter zone centered on the thinnest point. B was for back or posterior radius of curvature, again, centered on the thinnest point. C was for minimal corneal thickness, which is again, not an apical reading. And D is distance visual acuity. Distance visual acuity obviously is not something that the pentacam enters, but is user entered. In addition, we added an additional stage to AMSA-CRUMAC. AMSA-CRUMAC, everyone in the world has at least stage 1 disease, which clearly people do not. So we added a stage 0, which represents more of a normal cornea. So we have stage 0, 1, 2, 3, and 4. And again, each layer, each anatomical layer is individually graded. If you remember the example I gave you earlier, showing a normal anterior surface, but a highly abnormal posterior surface, with the ABCD classification, we again grade each anatomical layer separately. While this sounds confusing, it's actually done automatically by the machine. And currently, the staging or classification is part of the topometric keratoconus staging display. And it actually gives you a fair amount of information. The actual staging, which is the least useful information, is on the bottom. And here you can see A0, B4, C3, D0. So what does that mean? Well, it means the anterior surface, 0, is normal. This is a marked posterior ectasia, B4, moderately thin, C3, but again, because the anterior surface is normal, distance visual acuity is normal, D0. It's graphically shown on the upper right, but the most useful information, or the most precise information, is what you have on the left, which actually gives you the radius of curvature of 7.6 for the anterior surface, in that 3 millimeter zone, 4.82 for the posterior, thinnest pachymetry of 381, and a distance of 2020. Now you may say, why are we using radius of curvature as opposed to diopters, since diopters is kind of what most people are used for? Well, diopters are very intuitive for the anterior surface, but they actually are fairly non-intuitive or useless for the posterior corneal surface, because the posterior corneal surface is a low power minus lens, because again, as opposed to an air cornea interface, it's a cornea aqueous interface. So radius of curvature allows a better direct comparison between the anterior and posterior surface, where diopters really would not. So we're now going to go into some more background. And here we're going to go talk a little bit about the bad display. And the bad display, many of you are familiar with it. I believe it's at this point, it's probably the most commonly used refractive screening display. It again utilizes 9 different parameters in a regression analysis. It gives you an overall reading, which is a separation from normal. And I think that's very important. The bad display is a refractive screening display. It's designed to separate normal from abnormal. So the question I always get is, well, if we already have the bad display, why do we need a progression display? Well, again, the bad or the Belin-Ambrosia enhanced ectasia display is designed specifically to separate normal from abnormal. It's very useful. It's actually for refractive screening. It's, as I said, I think by far the most commonly used display, but it's not specific for ectatic disease. It gives you a risk analysis for refractive surgery. If you have someone who comes into your office in early corneal decompensation, they will have an abnormal bad display. They're not great candidates for refractive surgery, but that doesn't mean they have ectatic disease. It's designed, again, to separate normal from abnormal. It can be used as one of the inclusion criteria for keratoconus studies, but then again, you have to look at the map to make sure it's specific for ectatic disease and not any other abnormalities. The final D shows deviation from normal, but not necessarily progression of disease. So I think that's really an important thing to realize. The Belin ABC, we'll be discussing later, was designed specifically to follow and document progression of disease. It's based on one-sided confidence intervals. So that's really the big difference between, or one of the differences between the bad display and the progression display. The progression display is one-sided confidence intervals. In other words, we use corneal thickness. We're only interested if the cornea further thins, while the bad display will show changes in any direction. In other words, if you come in with someone with a cornea of 700 on the bad display, that's highly abnormal. But again, the progression display is specific for ectatic progression. It allows for documenting progression in spite of a stable anterior surface or a stable Kmax, and it evaluates each anatomical layer individually. I'll say this later, but let me say right from right now, one of the other advantages of the progression display is that you're able to go back and look at your older historical data. In other words, if you've had patients you've been following for a number of years, even prior to getting the new software, you can go back and analyze these patients. So you don't have to start from the time you have your new software. Your old data can be analyzed and incorporated into the progression display. So again, why a progression display? And again, this is an example of 3 different patients on the bad display. The one on your lower left is post-refractive. It's going to be obviously an abnormal bad display, and it should be. The patient already had refractive surgery. The one in the upper right is hyperopic LASIK, again, abnormal bad display. And the one on the lower right is what I kind of discussed earlier, someone with endothelial dysfunction, also a abnormal bad display, because again, all these eyes are not normal. It doesn't mean they're ectatic. So again, I want to stress the difference. The bad display is separating normal from abnormal, designed specifically for refractive screening. The progression display is disease specific and designed to follow ectatic disease. And again, I'm going to go back to that consensus document of 2015. In addition to their earlier statement that we had no classification system, the consensus document also stated that we had no way to follow patients. In other words, we had no way to monitor progression other than just looking at the anterior surface. But if you look at all the prior prior progression parameters, and if you look at this long list of progression parameters that people have written about, every single one of them, except for, I don't know if you can see my pointer or not, every single one except pachymetry are anterior surface parameters. None of them have been validated. And they're all just a mishmash of different parameters. But again, other than pachymetry, none of them are, they're all basically anterior surface parameters. And the reliance, and most studies have been done with Kmax, and the reliance on Kmax, both as an efficacy parameter and an indicator of progression, has resulted in irreversible loss of vision, delayed intervention, and has really, in the US, I know in many countries in Europe, the regulatory companies, whether it's insurance companies or your country's health plan, mandate that you document changes in Kmax. Hopefully that will change shortly, because again, this is a late change on the anterior surface, and it really means pretty much that your patient has already lost vision. The ABC classification, again, is measured at the cone, at the thinnest point. And again, I'm going to just repeat this. A was the anterior radius of curvature from a 3mm zone, centered at the thinnest point. B is the posterior or back radius of curvature from a 3mm zone, centered on the thinnest. C is the minimal corneal thickness, and D is best spectral corrected distance visual acuity. But the real goal of developing that new classification wasn't just to stop at a classification. The real goal of it was to allow us to use that information and to develop a progression display, to know when and if progression occurs, and to be able to identify it, not at the late stage with Kmax, not at the late stage with anterior surface parameters, but to determine progression at the earliest possible stage. And in order to do that, we needed to determine the background noise for each of these parameters. In other words, we needed to know when we had true statistical change, because all these measurements have inherent noise. Now, the A and B, again, anterior and posterior radius of curvature at the thinnest point in the 3mm zone, are new parameters that were developed basically for the ABCD classification. So we didn't have noise measurements for any of those. And we decided it was also important to study both normal patients and abnormal, meaning keratoconic patients. And the reason for that is, for your older patients with clinically evident keratoconus, the noise levels from the keratoconic patient database is more appropriate to use. And we know that patients with keratoconus inherently have more noise in their measurements. Additionally, your older patients are less likely to exhibit rapid change, and the risk of waiting is low. In other words, you can follow them. The younger patients, or those with very early or subclinical disease, probably mimic the noise level of a more normal population. Additionally, the younger patients are known to have more progressive disease. So there, the risk of waiting is higher. So again, we have noise levels based on two different populations. The normal population, which probably is more closely related to the early subclinical patient, and the established keratoconic patient. And if we look at the one-sided confidence intervals, you see exactly what we would anticipate. And red are the keratoconics, green are the normals, and what you will see is, again, what we anticipate, that the noise levels of the keratoconic patients are greater than those in the normal patients. And here we develop both a 95% confidence interval, one-sided tail, and an 80% one-sided tail confidence interval. And I'll show you later why, or I'll tell you later why we chose to use both the 80 and 95% confidence intervals. And this is the current progression display. So some of you, hopefully you all have the new software. The older software, which was version 1, was not nearly as visual as this. Again, the software updates, I believe, are supplied by OCULUS gratis, so you should all make sure you have the current software. I'm going to go over now the details of the display. There's a lot on the display that you may or may not ever really use, but it's important to know it's there. I want to start off by why we chose an 80 and 95% confidence intervals. Well, 95% confidence intervals is fairly typical in the medical literature. In other words, the 5% false positive rate. So that's a good comfort level. But 80%, if you have two parameters at the 80% level, that's effectively the same as a single parameter at the 95% level. If you actually, it equals about 96%. So we list both the 80% and 95% confidence intervals. Here you'll notice in red, and again, I'm not sure if my pointer comes through or not, but the solid line represents the 95% confidence interval. The dashed line represents the 80%. The numbers in red are the keratoconic populations. In green are the normal. And again, as we discussed earlier, the noise levels are further or greater for the keratoconic population. So again, dashed line 80%, solid line 95%. So this is an example here you can see. This is the baseline exam, and I'll go over more about this later. And actually, why don't we just go on to the next display? In addition to the graphical display of the ABCD, we also give you a tabular format of a number of other progression parameters that have been used in the past. So here again, we list the date, the time of the exam, the actual ABCD classification, the BAD-D, the progression index, ART max, Kmax, because a lot of people still need to follow that, Q values, the anterior surface parameters, and again, to make sure that here that you have a good quality check. You're also able to click off if and when you've done a treatment. You'll notice here treatment, and if you click off a treatment, that will show as a dotted line here. So everything below here, when we say treatment, we're usually talking about cross-linking. So everything below here is post-cross-linking. For those of you who have heard me talk before, I use a lot of car analogies because I'm kind of a car person. And the ABCD progression play is somewhat like a new car manual. There's a lot of features that you'll probably never use. Unfortunately, many of you probably never read the manual, but it's nice to know they are there. So let's go over some of them. First, what you will use, you identify your baseline exam. And that's putting a check right here. And again, as I said earlier, you can go back and analyze your historical data. In other words, all your earlier maps prior to installing the display can be analyzed. Then, if you've done a treatment, you then mark off a treatment here. You also can choose what population you want to display it against. The normal population, again, for young patients, for early disease, or the keratoconic. It will default to showing both. So here you can see this is the same patient, but here I chose to only display it against the normal population, again, on the upper, and here on the keratoconic on the lower. So again, it will default to showing both, but sometimes it may be advantageous to choose only one, and particularly if you're looking at a young patient with early disease, it may be advantageous only to show the green, the normal population, because that'll show change earlier. So if someone doesn't question why you treated someone if they haven't reached statistical significance in the red. You also can display, and most of you will probably never use this feature, you can display the data two different ways, and this is probably the most confusing aspect for people to understand. It's called aligned at baseline or full scale. It defaults to what's called aligned at baseline. And aligned at baseline, I'm probably going to say this twice because it is confusing to most people. Aligned at baseline graphically displays each parameter in its own scale. So if you look here, You see this says, and again, this may be hard to see on the screen, it says 1.0 here and 1.5 here, but if we go back to the B parameter, it's 2.5 and 3.0, and here it's a different number. So each parameter is graphically displayed to give you the maximal separation. In other words, to make it easiest to see whether there's been change or not. The full scale, what you have here on the right, if you notice, if I look at the 1.0 here, it goes across all the displays. So it's using the same scale for all of them. But if you notice what's happened when I go to full scale, notice how bunched up close these confidence intervals are. So full scale, the advantage of full scale, it preserves the relative ABCD staging at the loss of the fact that it becomes difficult to see when you've reached confidence intervals. So for most of the time, most people will not ever use full scale, but aligned at baseline, again, I want you to stress that each of these parameters is on its own graphical display. In other words, each scale is individual for each parameter, but it maximizes the separation. It allows us to, it makes it easier for us to see when and if we've reached the confidence intervals. Now, I mentioned that this is kind of like a car manual. There's a lot of features that you will never use, but actually, this is a closer pickup here. So aligned at baseline is best for determining progression. It maximizes separation at the expense of losing the relative anatomical gradient. Here it becomes much easier because it's a much larger picture. You can see again, each anatomical gradient is at a different scale. And here, the full scale, you can see again, it's the same scale throughout, but notice how close these confidence intervals are. Now, for those who want to get fancy, there's a way to kind of combine the benefits of both. And on the lower part of the map, you have a ability to magnify any aspect of the map that you want. So here you can see you can make the magnification greater. Here you can return it to normal. So you could combine full scale with magnification, and that's what we've done here, which allows us to keep the relative grading the same, but again, will magnify or increase the separation. Again, a nice feature. If I was giving a talk, it may be something I would show, but normal in my clinic, I would never really do this. The aligned at baseline is the normal default and really what all of you are going to be using. So again, if I look at the full scale over here, you can see how close these are, but if I use the magnification feature, I can increase the separation. But again, aligned at baseline is the easiest to use and probably what you're going to be using 99% of the time. Another feature that is there that I don't think most of you will be using is a bilateral display. It's nice to be able to show both eyes at the same time, yet it's a lot of information that's crammed onto one page, and by doing that again, you lose some of the visual separation. So again, I normally don't recommend using a bilateral display. I said earlier that we define our baseline, and your baseline can be really any exam that you want. Typically, it defaults to the first exam. And then you can define a treatment. And if you define a treatment, it will show as a hatched line, and all the confidence intervals will no longer appear after you've indicated a treatment. And the reason for that is our confidence intervals, our noise measurements, are based on pre-treatment eyes, on either normal eyes or keratoconic eyes, but eyes that have not been treated with either rings, cross-linking, or etc. So again, you can see here, this is a patient that by the second exam, notice we've well past the 95% confidence interval here. Here we're at past the 80% confidence interval. Here on the corneal thickness, we're way past the 95%. So this patient was treated, but notice after treatment, there were no longer any confidence intervals. Because again, the noise levels are developed in a normal and keratoconic non-treated patient population. Let's look at a couple examples. This is a 15-year-old with advanced keratoconus, 7-year follow-up. Now, this is a very good example. This map has not been available for 7 years, but again, we can go back and look at our historical data. And here, you can see that this patient continues to have progressive disease on the anterior surface, continues to have progressive disease on the posterior surface, and continues to show corneal thinning. Obviously, markedly progressive disease. And if you look at the parameter that people used to use, Kmax, you'll see it continues to increase. But what's the value of this? Well, this is the value. So here's a 15-year-old with very early keratoconus, 13-month follow-up. Almost no change on the anterior surface. But look at the posterior surface. Highly statistically significant change by the second exam, past the 80% confidence interval, and by the third exam, past the 95% confidence interval. But look at Kmax. Kmax has not changed one bit. So again, we wouldn't anticipate it because the anterior surface is normal. But here we have documented progressive disease in a 15-year-old with stable Kmax. This patient needs to be treated to preserve vision. Waiting till you see changes on the anterior surface means that you've basically had this patient lose vision rather than preserving good quality vision. So again, the goal should be not waiting till we have a problem. In other words, we don't treat high blood pressure only after someone has a stroke. The goal is to prevent the stroke. Our goal here should be to preserve vision, prevent loss of vision, not wait until we have loss of vision. Here's a 16-year-old, again, progressive subclinical disease. We look at the anterior surface. It's only two exams here. We can see the anterior surface is past the 95% confidence interval for the normal population. The posterior surface, again, well past the 95. Corneal thickness, every parameter here is actually past the 95% confidence interval. But look at Kmax. It doesn't meet that one diopter classification that most people use. So again, here's a patient, young patient with early disease showing progressive change on every anatomical layer, but doesn't meet that one diopter Kmax. Again, a limitation of only looking at one single parameter. Here's an 18-year-old with stable Kmax. You can see here the Kmax was 48.6 and 48.4, effectively no change. 46.2 actually got better, 44.2. But look what's going on at the posterior surface. Not as dramatic on the right eye, but look at the left eye. Marked progression on the posterior surface. Again, documented progression, reason to intervene in spite of the fact that the patient has normal vision. And again, normal, or now say normal, but no changes in Kmax. Now, rather than looking at subclinical disease, here's a patient with more advanced keratoconus. If we go back and look at the Ds, notice they were already in the 7 standard deviation outside the norm, so this no longer is early disease. But look at Kmax, 51.2, 52.1, 51.9, 50.3. Never do we see a one diopter change. The anterior surface sees stable, but again, look what's going on the back surface and on pachymetry. Well past the here's to the 80% confidence interval and here to the 95%, in spite of the fact that we have a stable Kmax. So progressive disease, documented progressive disease, in a patient with fairly advanced disease, in spite of the fact that we have a stable Kmax. So how do we diagnose progression of keratoconus? Well, we recognize that there's a dissociation of the clinical progression with changes in Kmax. I think everyone now in the field, if at any meeting, everyone recognizes that Kmax really is a terrible parameter. Yet, that's what most people use, and that's what, unfortunately, a lot of the insurance companies or health plans or national health services mandate that we document changes in Kmax. I can tell you that there are a number of studies ongoing now that's been accepted that no longer utilize Kmax. I think people recognize it really is not the optimal parameter. We recognize that a tomographic-based classification system, one that recognizes all the anatomical layers. We now have a tomographic-based progression display that documents statistically significant change and looks at each anatomical layer. And as I already said, the progression display may be used on older historical files. You can go back and review past information with the new software. So if you've been following someone for a period of time, again, your older maps can be incorporated into this display. I think that's extremely important. So the last part, and what will be the next iteration of the progression display, we've always been asked, well, how do you define progression after cross-linking? And I already said that the progression parameters after cross-linking are really have been unknown. And currently, the confidence intervals, as you can see again, I've showed this map before, the confidence intervals are actually dropped once you've indicated you've done a treatment, because they were developed again on a non-treated patient population. The next version of the Belin ABCD, which I hope will be out by ESCRS, if we have ESCRS, will incorporate post-cross-linking parameters. And this is a study that we've completed. It was done with the Elzer Institute in Zurich. It's been submitted to ESCRS, and I'll just kind of read. This is pretty much from our abstract. The current study was designed to measure noise of post-cross-linking eyes and evaluate whether these measurements can serve as progression determinants after cross-linking. We did 3 separate Pentacam measurements. They were taken by removing the patient from the Pentacam device between each measurement. We required a minimum of 7.5 millimeters of coverage and acceptable quality scores. And then again, we did statistical analysis, variance estimates, one-side confidence intervals. We looked at 41 eyes with an average age of 32.9. We had a minimal follow-up of 9 months with an average of 13.5. Most people recognize that really about 1 year after the vast majority of patients have stabilized, though we do know that some continue to change. The average D on these patients was 9.26 with a range of down to 1.12 up to almost 19. And again, we then developed both the same 80 and 95% one-sided confidence intervals. And these are our 80 and 95% one-sided confidence intervals for both the A, B, and C parameter post-cross-linking with, again, a minimal follow-up of 9 months with an average follow-up of over 1 year. And this is a beta version or a mock-up of what the display will look like. The post-cross-linking will probably be shown in the color of blue. And again, it will be very similar to the established green and red, showing again an 80% confidence interval and a 95% confidence interval for statistically significant change. And again, these will appear both on the A, B, and C parameters. And again, as I said, hopefully this will be something that will be available shortly, but then will allow us to follow patient cross-linking. They will only appear on the exam that's 10 months or later. So if you notice here, these tails do not go all the way up to that first exam. So the confidence intervals will only be shown at a 10-month or later period post cross-linking. And the reason for that is, again, we do know that there's a small subset of patients who may require repeat treatment. And the big question always is we don't know what the life duration of cross-linking is, particularly on the young patients, where the young patients need to be retreated later in life. But we do know that we do need to follow these patients and that some patients do require retreatment. So with that, I'd like to thank you for your attention. We do have some time left for questions, but I mentioned earlier, I actually kind of have to rush to get back to the hospital. Because of the COVID-19, our schedules are very strange, and they actually just assigned me an early time on Tuesday, which is not usually an early day for me. So Jorg, I don't know if you can take over for questions or not.
So thank you very much for sharing this in-depth knowledge about the Belin ABCD and also explaining what is the difference between Belin ABCDs and the Belin Abruzzo Enhanced Ectasia Display. We got some interesting questions, and I think we can almost cover them. How do you handle examinations in which the quality specification is shown in yellow or in red? Do you exclude them, or how does the software deal with it?
The progression display in Jorg, you can intervene if my answer technically is wrong from the software, but the machine actually searches for only the best quality exams. So if you have multiple exams on the same day, it will search for the one that actually gives the best quality score. It will not look at maps that don't meet its own internal quality.
Exactly right. So thank you. And there is more a scientific question. And the question is, I read it, where the 80 and 95% confidence intervals based on the parameter variation in the originally measured population, or were they based on the actual progression observed in the measured keratoconus population?
No, they're measured on a static population. It kind of would be, and I would have to think of this a little bit more, but that second way you word it would be somewhat impossible, because to develop noise of progression and say I'm doing it on a population that's progressive is kind of, you have to make an assumption that they really are progressive. So the noise level is done on a static population. It's done to develop what the inherent noise level is of that single parameter. But again, we recognize that, and we do know that noise levels on any abnormal patients are greater than they would be in a normal population.
For sure. Thank you. Another question is, and I think that's a question that is interesting to many, and they are looking for an answer. Would you advise treatment, for example, cross-linking based on just one parameter showing progression? Or if not, are you using any cutoff values, or what is your advice? What is your recommendation?
So I'll give you a general guideline, and this is really very general. So I said earlier that one parameter at the 95% confidence interval, or two parameters at the 80. And the reason I say two at the 80 is, again, if you have 80% confidence interval, you have a 20% chance of a false positive, but for two of them, you would have 20% of 20%, which is 4%, which gives you a 96% confidence interval. I usually tell people I'm a little bit uncomfortable only looking at two, in other words, one exam passed. So I like to show a third exam. The one time when I'll say that may not be true is on the very young patient who we know they have very progressive disease, but in general, I like to see at least three exams. Again, one parameter at the 95, or at least two at the 80%. But a lot of this also depends on, if someone has a strong family history, I would be more aggressive, but those are general guidelines.
And then another question results out of your answer. How would you ask patients to come back to the clinic to do follow-up exams? Is this with relation to age? Is this with relation to family history, to the parameters? Can you give us some more hints and explanation about this?
Yeah, and again, that's clinical practice, but clearly, let's say someone came in, and again, some people will say, you have let's say we use a 15-year-old. Some people will say you have a 15-year-old that you diagnose a cataract disease on. Some people will say you should treat it de facto. Others will say no, you need to document progression. A 15-year-old I may see back in 6 weeks, and if I see a change, I may see him again. That one would probably be adequate, but again, maybe another time in 6 weeks. Someone in their 20s, I may go, the first exam, see him back in 2 months. But if someone came in with established disease, that historically has been relatively stable in, let's say, their 40s, I may not see them for 3 months, and then if 3 months is stable, 6 months, and if they're stable at 6 months, yearly. So it's what you normally do in your normal practice, even before the progression display. The younger patients need to be seen more frequently. The older, more established, you can spread out. We do know that there are not an insignificant number of patients past the age of 35 or 40 who, however, continue to progress.
Sure. Thank you, Michael. And a question, this is also related to progression, comes in and says, well, does the software treat different exams in time differently regarding progression? Means if the time between 2 exams was 2 weeks or 3 months, is there any difference, or is it the same?
No, it doesn't change. No, it's showing you still just the 2 exams. It doesn't look at the interval of time between them.
Perfect. And then a question came in asking, can we use the ABCD progression display to follow up ectasia after LASIK? Any information about this, Michael?
Yes, that you can follow.